Well, thank you very much for the opportunity to present this concept of the real cost of training a surgeon. I don't have any disclosures. We want to pause for a definition very quickly. When you talk about cost, it's really the irreversible use of a resource. We think of money as cost, but there's also time, non-renewable resources, so there's more involved than just the sheer dollars and cents. So there's three areas of cost that we're going to look at. One is the institution, the other one is going to be the patients, and then the third is then on the trainee. So you look at the institution, really the question is, how much money does it take to train a general surgery resident? Is it $5,000, $50,000, $500,000? That's a very hard number to come by, quite frankly, and here's why. So one of the papers talked about direct and indirect costs. It's very easy for me to total up what it costs for the resident's salary and the benefits, some of the faculty development, also some of the simulation, but it's very difficult to get a number when it comes to the procedural costs when there's differences in times involved, variation in efficiency, differences in resource utilization. So quite frankly, it's a very difficult number to track down. Now we do one good job at studying one thing, and that is assessing trainee impact on operative time, comparable operative time with and without a surgery resident, effective resident involvement on operative time in operative room, and resident impact on operative duration. I did not put the times up there because I know you'd spend the rest of this presentation figuring out how much money you're losing by having residents work with you. And here's what the problem, here's what we were missing. Effective resident involvement on sleep patterns by not getting the Mrs. Smith's urine output is 100 milliliters for the last 4 hours, nursing call at 1 a.m. So it's very difficult for us to get a global pattern of understanding what it really truly does cost to train a resident. Now in the UK, they have done some work more than we have. Their economic structure is a little bit different, but they looked at almost 1,200 outpatient clinic visits. They converted everything to American dollars, but they did recognize that their reimbursement scheme is different from ours. And basically what they found out was this projected yearly income from the resident productivity offset 95% of the trainee's basic salary. And so again, trying to figure out what the true cost is for resident training in the United States is exceedingly difficult. So how much money does it take to train a general surgery resident? We have a decent idea for primary care outpatient training. If you ran across this article, it was recently published, the cost of training residents in teaching health centers. In 2011, the United States recognized that they needed more primary care physicians, and so they developed teaching health centers that were outside of the normal funding stream, and they had to have a separate budget for that. And what they found out in these community-based practices, that in 2017, it cost $157,000 to train those residents. When it comes for general surgery residents, we really don't know. We don't know my institution, and I would encourage you, if you have a better idea of what it costs at your institution, come and tell me, because nobody that I know of has really truly summed up what it financially costs to train a resident. So when it comes to the institution, we talk about the money it takes to train them, but we don't have a real solid idea on that. What about the patient? Well, who here hasn't heard, I don't want to have any resident operating on me? Why is that? Well, when you look at the cost, the irreversible use of resource for the patient, that's me. I don't want to be killed by a resident, nor do I want to be maimed. And the question is that true? Do residents actually harm patients? Now, we'll have another presentation that go in more detail on that concept, but I'll just give you one resource. Recently published, the association between teaching status and mortality in U.S. hospitals. They looked at 21 million visits from 2012 to 2014 at 4,400 hospitals on 6 surgical conditions. And what they found out, if you look at those 6 surgical conditions, that the mortality at teaching hospitals is actually less than at non-teaching hospitals. But again, that doesn't answer the question, though, what about the morbidity? How many times have I had patients ask me, would you close the incision because I want you to do it rather than the resident, because they're concerned that the scar would look worse if a resident did that? It's a very good question. I don't think that we have a great answer to that, and I look forward to the other presentations along that topic. So when it comes to the institution, we have the cost, which is very difficult to nail down. The patient, they're concerned that we would harm them. I think we'll find out that that's probably not true. But what about the trainee? What's the cost of the trainee? When it comes to the irreversible use of a resource, the very first thing is time. If you're in the American system, it's going to take at least 5 years of training. The American Board of Surgery has made that very clear that you have to put in 5 years of training. As I tell my residents, don't think of it as 5 years, just think of it half a decade. And that helps them to really feel like that it's a shorter amount of time. But it is a cost to them that we have to recognize that they're going to dedicate basically half a decade of their life with us, and we're going to dedicate to them in training. And that's not counting time in the lab at certain institutions. But the other cost is the personnel, which is very serious when it comes to attrition, and then actually after they leave training, early retirement. So what is the attrition rate? Recently published in JAMA, the prevalence and cause among general surgery residents, what they found in 22 studies, 19,000 residents, that the pooled estimate was 18% attrition rate. In other words, 9 out of every 50 people that enter our programs do not finish with us. And that's a fairly significant waste of resource, and it also is a fairly significant waste of their time if they could be selected to go into another specialty right off the bat. Now, why is that? Well, many of you have been well aware of the rate of burnout in the general surgery population for practicing surgeons, but it's also been studied with residents. This national survey of burnout among U.S. general surgery residents was recently published, but before we look at the numbers on that, I want to pause and remind you what burnout is, because it is different than depression. When you think about depression, that could be one event in a person's life that leads them to depression, but burnout, by the Maslach burnout inventory, expresses emotional exhaustion, that feeling that you're just emotionally overextended and exhausted in your work, depersonalization, that impersonal response toward recipients of your service and of your care, and then also that sense of personal accomplishment that you're not actually accomplishing what it is that you want in your life. I like this quote from Dr. Gunderman that has really stuck in my mind when it comes to burnout. Back in 2014, he published this article and he said, "Professional burnout is a sum total of hundreds of thousands of tiny betrayal of purpose, each one so minute that it hardly attracts notice." And I think that captures burnout more so than one glorious event in a person's life that puts them over the edge. Is that constantly pulling that ball of anxiety and stress that we place upon our residents day in and day out that leads to depression, leads to burnout. So what did the national survey show with that concept of burnout in mind? Well, they looked at 753 residents, and they found out that 69% of them were burned out. So what happens? They enter surgery residency and they think it's going to be like this, and they find out that it's like this, and it's just a little bit too much for them. So what can we do? What are 2 possible solutions to help this? One is the selection process, and the other one is in mentoring. When we come to the selection process for residents, our own Brian Duncan has published this, stressing us to consider the science of selection rather than just gathering all the surgeons around and say, "Hey, do you like this guy? Do you like that gal?" Let's have better evidence as far as selecting residents by looking at personal inventories, looking at situational judgment tests, and also having standard interviews. But I'd also suggest one other thing that's hitting the market. Grit as a marker for residents at risk for attrition, and grit or as a predictor of risk as attrition. If you've not been using this, I'd encourage you to pick up Duckworth's book on grit and start thinking about that as the concept of selecting the people that are going into general surgery residency. It is difficult, it is hard, you need people that are going to go against the flow, and there is science behind selecting people that are better equipped to do that, and I encourage you to check this out. The second thing on the selection process is mentoring. All of the studies that I showed when it comes to attrition and depression, every single one of them boiled down to this: preventing general surgery residency attrition is all about mentoring. Our own Julie Flashag published that. And then a resident followed up, Molly Wasserman from Northwestern University, a strategy. And what was that strategy? Mentoring. And so the 2 things that I encourage you to consider walking away from this short presentation is rethink through your selection process for the residents in your program. And then secondly, like we're doing at our institution, we're developing a standardized mentoring process that we're going to put in place starting next year for our residents. So what's the real cost of training a surgeon? I looked at cost as an irreversible use of a resource. For the institution, it was the money. It's very difficult to nail that down. For the patients, it's personal harm, but I'd question whether or not they're actually harmed. But for the trainee, it's the time they put into training. They'll never get that back. A high attrition rate and burnout, which has been well studied. Now, I know that what all the trainees are thinking when it be a lot better when I'm attending, but I'll leave that up for you guys to judge whether or not that's true. So thank you very much.